everyone. I would like to welcome you to all this I3 webinar session all about Oocyte as a new KPI. So this webinar is kindly sponsored by Future Fertility. I am delighted to be joined by my co-host, firstly, Nacho Landaburu. So he is the senior clinical embryologist and head of the laboratories at KPI clinics in Zurich. So he is also founding team member of the clinic with over 15 years experience working in and leading the IVF laboratories across Europe. His current research is partnership with University of Lucerne and explores how the circadian rhythms influence fertility. And also, we are joined today by our lovely friend, Julian Filstadt. So we love her so much. So she is the head of clinical embryology and scientific operations for Future Fertility. She works closely with the partnering clinics to ensure smooth onboarding the innovative artificial based tools within their laboratories. Julian?
Thank you. Thank you so much, Munevver. You're so kind. I'm definitely happy to be here at Future Fertility. As mentioned, we collaborate closely with labs all around the world, using our clinically validated AI models to bring more objectivity and clarity to oocyte quality assessments. And through our continued work, we're seeing that one thing is really clear about oocyte assessments is that oocyte quality has a major impact on downstream outcomes, yet it remains one of the least standardized metrics in our field of IVF. So we're proud to bring today's I3 session together and discuss and help shine light on the value of emerging as oocytes as an emerging KPI, and we can bring this to both the lab and the clinical team. So thank you, and I'll pass it on to Nacho.
Thank you so much, Jolene. Also, thank you, Munevver. Let me introduce her. She's the only one left. Let me say a couple of words about her. So Munevver is scientific director with over 16 years of experience in Ventus IVF Center. She has taken on responsibilities within ESRE, such as ESRE Journal Club editorial team, ESRE Male Reproductive Health Initiatives Core Working Group, and also International Reproductive Health Education Collaboration Steering Committee. Also, ESRE Female Reproductive Genetics Initiative. So she knows how to keep herself busy. One last thing, please remember to place all your questions in the Q&A section, not in the chat. This is then easier for the organization to select them for the section we're going to have after the three incredible speakers that are coming up.
Thank you, Nacho, for the good introduction. So I would like to give my pleasure to introduce our first speaker, Dr. Yosu Franco Iriarte, with the doctorate in molecular biology. So he has developed his professional career linked to assisted reproduction, occupying various positions of high prestige. He is the director of reproduction laboratory of the Ruber International Hospital, where his main functions consisted of developing research and encouraging the use of new technologies. Dr. Yosu, the floor is yours. Welcome.
Thank you. Thank you for everybody. Here is night. Good night from Spain. And it's a pleasure to share with you and try to collaborate and always share science. My presentation, the topic is like before to start to speak about the intelligence, how we can go to the intelligence area, is the history of the eggs in culture. What happened? Normally, we want to do like, what with the eggs or the oocyte should we select? Because we are going to find in the laboratory different kind of oocyte. We can find the diffuse granularity, the centrality granularity, the backwards, the CER, the DAR and fixed CP. And this kind of morphology characteristics, we have to select or we have to decide what we are going to do with this oocyte. But what's the problem? Always is subjectivity, is not objectivity, and we don't know what is going to happen with this kind of size if we are going to have like blastocyst states or what is going to happen in the final cycle of IVF. Because when we have to check what is the ideal oocyte, in 2008, Swine and Poole, the definition, what is the ideal oocyte, is the oocyte with a normal appearance and with a spherical shape, homogeneous cytoplasmatic with no inclusions and uniform pellucida, and with 3 layers glycoproteins and no small perivitellin space, no higher, smaller. And what happens in the IVF cycles, normally only the 30% of the collect oocyte have an ideal morphology. And this is one of the things we have to improve, or we have to check what is going to happen. If we check in general what is going to happen in Europe, for example, and the comparison with the oocyte and the cryopreservation in the oocyte, I can see here in the graphic between 2013 until 2022 in the register in Europe, you can see how many oocytes are vitrified, more than 9,000 oocytes in 2013, when the vitrification started to appear and to be more stronger. But in 2022 is more than 40,000 vitrified oocytes, is growing exponentially. And what happened, for example, in USA? In USA, we have these kind of graphics also this year are collected 2014 until 2022. And you can see also the growing in the vitrification oocyte. And in this kind of vitrification, we have to check that, for example, if we have in the median or in the egg retrieval 10 oocyte, how is normally the number of the oocyte we have between 2014 until 2022. But in the median of the collection of the eggs is going to be 13 oocytes, then we have this kind of numbers. And you see how is in general the vitrification of how it's working around the world. But what happened when we had to focus in this technique and the cryopreservation and the quality of the oocyte is good, we have to check what is going to happen in the survival rate and also how is the live-by rate, because for me is the best KPI. And checking the collection of the data in USA, the survival rate in general is 85% is survival rate in oocyte from the oocyte are vitrified, but the live-by rate is only 30% because you can check, oh my God, 30% is a small number. And this is the number we have in the future, we have to improve. And what happened in the earlier registry? In the earlier registry, if we are going to focus in another kind of oocyte, for example, in the egg donation, 3 years or 2 years before, registered in Europe more than 82,000 cycles in egg donation. And if we are going to focus in my country, in Spain, 35,000 cycles in egg donation are done. There are so many cycles. And we go to the registration ESF, is the scientific register here in Spain, to focus what are the results. And we can see that normally when we are going to check the delivery from this kind of oocyte is going to be 42.2%. And if we compare the oocyte between the egg donation with the oocyte from the patients, you can see specifically in the last line, the live-by rate is going to be 31.2% from oocytes coming from the patient, and from egg donation is 40%. These kind of numbers, again, start to increase with the egg donation, but for me is low number. Then the modern advance in vitrification or with the oocyte, what is going to happen in the history? In 2000s, started vitrification, replaces the low freezing, we know. Again, later, the in vitro maturation start to appear, and now our focus, how we can improve this kind of technique, try to have more efficient, and the artificial ovarian and organoid research in the last years. But we are going to focus specifically what we are doing every day and in the quality of the oocyte and what happened with the morphological assessment of the oocyte. Then what we have to evaluate, what parameters we have to evaluate. We can evaluate the cytoplasmatic morphological alterations. We can evaluate the extracytoplasmatic morphological alterations, or how are the cumulus coronal radiata oocyte complex. But if we're not going to focus in the cytoplasmatic morphological alteration, we can find different options what we are going to check by microscope. And we can see the organelle groupings of the granularity. And what happened with this, because when you see the papers, there are different controversies that is going to work or no. And normally, they are going to tell you that this kind of size, they are going to have low implantation potential. And normally, this kind of sites, 8%, 8.3% of the oocytes, they are going to have a good quality, specifically in the blastocyst stage. But more alterations in the morphological alteration is going to be the REL. And what happened with this? Because there are so many controversies about this kind of size in the characteristics. Normally, when you check the papers and the literature, they are going to tell you that the negative results from this kind of oocyte, there are going to be abnormal development of the embryo, low blastocyst stage, and when you are going to transfer blastocysts coming from this kind of oocytes, the biochemical pregnancy starts to increase, and also obstetric complications. And I am telling you this, the last line, because appeared 2 years ago by Long, this paper telling us that this kind of oocyte, they are related with a risk of neonatal bite defects. And there are a point, this is important to account. Then we have more cytoplasmatic morphological alterations, and we can find the back walls. And depending on the size of the back walls, also the results that are going to be totally different. We can have a small and few that normally they don't have a negative impact, but when are large, more than 14 micrometers, we can find failure in the fertilization and also a low blastocyst formation rate. And with the inclusions, what happened with this kind of inclusions? The literature is not going to tell you anything about it. There are so many controversies. And morphological assessment in the oocyte, there are going to be the extracytoplasmatic morphological alteration. And what happened here? What kind of oocytes, quality of size we can find it? We can find cellular remains in the perivitellin space, and this kind of structures we can find depend on the characteristics of the patients, anomalies in the zona pellucida, and increase the perivitellin space or alterations in the first polar body. And when we check the literature, specifically with the first, the cellular remains, there are no evidence associated with poor embryo quality, and normally is associated with lower implantation rate. But what happened with the anomalies in the zona pellucida? Also in the papers or in the literature, these kind of oocytes are associated with low implantation rate. With the space perivitellins, is low fertilization, but is not be related with very bad quality of the embryos. And in the alteration in the first polar body, we can find different structures. We can have fragmented polar body, or if it's bigger, normally the fragmenting has controversy and not related with the quality of the embryo, but is the polar body and is big, is associated with aneuploidy. Then what are the recommendations in general with the literature? Unfavorable with the quality of the oocytes, there are going to be like 4 points, different points. The accumulation of a smooth endoplasmic reticulum, the first large polar body, more than 30 micrometers, excessive vacuolation, and young oocyte. What we can tell us the ERSWE. Laura Rienzi, in this paper, published a long time ago the analysis or try to figure out what is going to happen with all the papers, and in this review is going to tell us there are indicators or a few characteristics that are going to be implemented or related with low implantation of biochemical pregnancy, and it's necessary to be of focus in 2 characteristics. We don't have to use it in the young oocyte and the ESR clusters. But we have to vitrify all the oocyte, or we have to use the oocyte, or we have to select. This is important specifically to be efficient for the patients. And what number of the oocytes we have to be advisable to vitrify in case it's necessary to vitrify the oocyte, or in case it's necessary to use for a PGTA cycle. And if we have to predict there are different articles that are going to tell us how many oocytes are necessary to vitrify or how many oocytes is efficient to have a very good results. And some groups suggest vitrifying less, at least between 10 and 20 oocytes depending on the age of the patients. This graphic is very, very interesting, and everybody knows this graphic because depending on the number of the mature oocytes are necessary to use it, and depending on related with the age, we are going to have more number to use oocytes to have a live birth, and this is the main KPI. One paper very interesting tell us if we are going to check this formula, and in this formula, the 0.95 is going to suppose that you have a 95% of survival rate in oocyte when you are going to use. And it's going to assume that you have under 35 years, the survival rate in 95, like I told you, and we are going to check what happened if we are going to have, or we are going to start with each oocyte, and depending on the age, how many blastocysts you are going to have, specifically related with the quality of the oocyte. And you have 34 years and 8 oocytes, and you select very good quality, you are going to have 3 blastocysts. You have 37, 2 blastocysts, but you have 42 years, only 1 blastocyst. And what is the probability 1 blastocyst, depending on the age or the quality of the oocytes, could be euploid? That less than 35 years, normally the probability to have a blastocyst and its euploid coming from a good oocyte is 57.4%, less than 35 years, and 12% for 44 years. But normally the main of the patients, they have, or the median is 37 years. And what is the probability to have this blastocyst was euploid? Is 48.6%. Then, if we are going to relate it with the graphic I showed you before, and we have these 3 kind of patients with 34, 37, and 42 years, we are going to have 20 oocytes coming from 20 sites. This is at least 1 child, and this is the percentage we have it. But if we want to be less efficiency and 75%, with 34 years, we need 10 oocytes. With 37, we need 20 oocytes. But with 42 years, we need 61 oocytes. And this is very important to check, to focus, to have very clear in the clinic, and to give this information also to the patients. But how we can measure the quality of the oocyte? Because at the moment, there are no validated compatible systems. And normally, like I showed you before, the dysmorphins not correlated with the oocyte potential. Then it's very important to figure out what is going to be the future and to have a visual assessment, and don't have to be subjective. We have to focus in something is going to be more objective. Why? Because it's very important the medicine personalized. Then, when we are going to check the morphological evaluation of the oocyte, how we have to interpret the results? We can use something that help us to be more efficiency with the data we showed you before, not only with the data we needed, the number of the oocyte for vitrification, that also what is the quality of the oocyte and how we are going to give this information to the patients. Then it's very important start to introduce an artificial intelligence system to check or to help us if we can improve their results. But what happens when we are going to introduce the artificial intelligence in the regular world? Start to the anxiety of the artificial intelligence, because we don't know if we are going to lose the privacy, not for us, also for the patients. What is the perception of the patients if we are going to use this artificial intelligence? And normally for embryologists, we can have afraid the job replacement, because it's very important in this privacy has to be ethics, regulation, what is the cost and the accessibility. But for the perception of the patient, it's very important to have more objective information, specifically to have better relation patient-clinic. And when we are going to introduce this artificial intelligence, how is the interpretability? Very, very important. For the reason, and I don't want to extend more time because I think it's much better to do discussion and only like 20 minutes to introduce the rest of the artificial intelligence. The conclusions are we need a procedure more efficient. The artificial intelligence has come to stay and is necessary to work with them and start to validate the systems within the clinical part of the laboratory. It's necessary to check every oocyte, not only what is going to happen with one oocyte, but the characteristic and the dimorphisms if each oocyte, if it's going to be more efficient, or we can have more information about this kind of sites. And for the future, to have prediction for blastocyst and neuploid could have to improve and help to be more efficient in the treatments. Thank you so much. Open to the question.
Thank you very, very much, Yosu, for this very nice presentation, very comprehensive. There seems to be a lot of questions from the audience regarding the consensus, and I would like to try to summarize it in where do you stand in terms of consensus? Do you stand in Vienna? Do you stand in Istanbul? Or you stand in Esre or Asabir?
Normally, I check all the consensus to check what is going to happen or what they are going to tell us. But the last numbers I told you was the Vienna consensus.
Okay, so you wouldn't throw away an oocyte showing smooth endoplasmatic reticle.
Yeah, but the plasmatic reticle are normally the problem is like normally when you check all the papers, they are going to tell you that you have to tell the patient what is going to happen and the less efficiency for this kind of oocytes. And you have blastocyst, has to be the last chance to transfer, but we have to focus paper we show because the risk to have a neonatal birth is more than 3.5% more than in the regular oocyte. Then it's necessary to know this information and to give to the patient to know everything very clear.
All right, thank you so much.
You are welcome.
So moving on to our next speaker, he's Dr. Dan Nayot. He's a reproductive endocrinologist, an infertility specialist at the Reproductive Care Center in Canada. He's also medical director at the Fertility Partners, a North American IVF network, co-founder and chief medical officer of Future Fertility. Dr. Nayot earned his BSc in mathematics from the University of Toronto, MD from Western University. He also has a Master of Clinical Epidemiology from Harvard, and he's OB-GYN from the University of Toronto. He also has a fellowship from the McGill University. He combines medicine and mathematics to drive innovation, research, and accessibility in fertility care. Thank you for being here, Dr. Nayot. The floor is yours.
Okay, thank you, Nacho. So I'm working out of my home office, so there's a very good chance some kids are going to run in here, but we'll do our best. Let me share my screen. Yasu, thank you so much for the presentation. It's a good setup for mine, and I appreciate it. Just confirming you can see my screen here.
It looks good.
Can you hear? Yeah, you see it. Okay, great.
Yes,
So it's a real honor to present. As Nacho said, my name is Dan. I'm a fertility doctor, and I'm honored to be the co-founder and the CMO of Future Fertility. I've been working for 8 years, day and night, to try to, unlock this oocyte quality assessment, and I really believe artificial intelligence is the way. And so today we're going to talk to you that how we're going to use oocyte quality to give us some feedback on stimulation protocols. And as Yasu mentioned, we're not really good at measuring oocyte quality, so maybe AI could do that. And once we could do that, then we finally have some feedback. Specifically, I'm going to talk about 3 research projects that were done that sort of shows us what we're talking about. But the main thesis is that all oops, you guys can see. All parts of the fertility assessments are evaluated. Hormones we measure all the time. Sperm, we do a semen analysis, DNA fragmentation. Every embryo in the world is graded, even if we discard it, even if we test it, even if there's just one. And of course, the endometrium, there's ultrasound and endometrial biopsy. But as Yasu mentioned, in the oocyte, there is still no validated egg scoring system. And the thesis here is if there was, when somebody comes up with it, a visual scoring system, then of course every egg is going to be evaluated because we know egg is the primary driver of embryo quality, and some would say the main reason why fertility rates are going down over time. So when I speak to patients, I always say that IVF is not only treatment, we're trying to get you pregnant, but it's also diagnostic. It's the first time we see your eggs. It's the first time we see your sperm together and watch embryo development. So it's a really useful tool. It's not just about getting success, but getting some insights as well. Now, we measure every single thing that we can. Now, if you're going to do ICSI, you can make an argument, what's the point of measuring the semen analysis, whether it's 1 million, 10 million, 100 million, you're just picking one, but of course we're measuring every semen analysis. Same with embryos. If you have a single embryo, you're either going to get pregnant or you're not going to get pregnant. There's no selection, but of course you're going to grade your embryo because we need to give patients feedback. This is a high quality or low quality. Do we think it failed because of embryo or not embryo? And the same for endometrium. So as a general rule, as we all know, if we can't measure it objectively, then we cannot improve it. And one KPI that we're going to be talking about today is oocyte quality KPI. And I'd like to show you how AI can create this KPI and then how we can use it in the lab. Okay, so when things go well, it's great. It's a happy patient, happy doctor, happy lab. When things don't go as well, there's always this triad effect. We're always wondering, is it the patient? She's 44, it's an underlying egg quality. Is it the clinical factors, the way I made the stimulation protocol when I decided to trigger, or is it related to the lab? Who did the ICSI? What were the culture conditions in? When was the last time the embryoscope was serviced, and so forth? And so having some feedback is extremely helpful for us. Okay. This is a new paper that just came out from some experts in our field. You might be on this webinar already, but essentially just telling us that there is no way to evaluate eggs. There is no validated scoring system, and AI is the future. With AI, we can finally tell a little bit about the underlying egg score, and we can use this in different scenarios, in egg donation, in egg freezing, and in egg usage. Excuse me. Okay, so how do we make an AI tool? So this is called Magenta. And what we tried to do is we want to make sure it doesn't affect the flow. So we took eggs, we denude them, we put it under microscope, and we don't put any extra equipment. So this is the same microscope that you would always use, and it would be automatic. It could be in the camera, it can be in the time lapse, and it gives you a report automatically. So this is non-invasive, this is real time, and it gives you a score for every individual egg. The key here is the workflow. We don't want embryologists to do extra steps. We don't want them to have to rotate the eggs, and we want immediate feedback. This is what the Magenta score looks like. So here you can see a picture of an egg. This is a denuded mature egg, and a Magenta score out of 10. And again, a score is correlated to its ability to reach a high quality blastocyst. So a low score should represent a low potential for an egg, and a high score, high potential. One thing that I think is super important is here you see a report, and we have a total of 2 + 4 + 2, so 8 eggs. And you can see that not all eggs would be categorized in the same score. And this is what we see in real practice. I always tell my patients, that's great, you have 10 mature eggs, but I've personally never seen 10 eggs turn into 10 blasts and 10 babies, because we know that not all eggs in the same cohort have the same reproductive potential. So this is what a Magenta score looks like when patients get it. They can see the diversification. Now, what Yasu mentioned is actually, if you Google it, there is no definition for egg quality. There's no definition for it, but I think what we all mean clinically is what is the reproductive potential of that egg. So if this egg has the reproductive potential to become a blastocyst in a baby, we all agree this is a high quality egg. And if it doesn't, it's a low quality egg. And so I want to show you some of our data that I think summarizes how AI tells us about egg quality. So this is based on over 650,000 images of mature eggs and knowing their outcomes. So if you took all those eggs and you looked at eggs that did not fertilize, if ICSI, the average magenta score is 4.7. You took all those eggs that fertilized but did not make it to the blastocyst, you'll see that the average magenta score goes up to 5.4. If you took these eggs that fertilized, made it into embryo, and in fact, all the way to good quality embryos, you have an average score of 6.9 and onwards and onwards. Here, you can see that the average magenta score of an egg that makes it all the way to a blastocyst that implants is 7.7. So again, this is congruent with our definition for egg scoring. The reproductive potential of an egg is correlated to the magenta score, and you see this biological gradient. I will not spend any time to show you all our validations. I could just tell you that in the last 8 years, we've accumulated over 650,000 images. We've have about 65 validated abstracts, 6 manuscripts, 2 book chapters, and worked with leading key opinion leaders in clinics around the world. We've measured anything from fertilization to euploidy status, both in microscope and time lapse, in fresh eggs and donor eggs. And so hopefully you can now accept that an AI tool can give you some insights into the egg. So that means we can move on and talk about, we have a tool that can look at mature eggs and can give us an objective metric of how the egg quality is. So how would we use such a tool? Well, I believe that if there was an egg scoring system, every egg would be used, whether you're freezing these eggs, donating these eggs, inseminating these eggs, discarding these eggs. But it can give us some insight specifically about the stimulation protocols, a little bit about subgroups, endometriosis patients, smoking patients, older patients, and it can give us some real-time feedback. Again, a new KPI that we didn't have before, an oocyte quality. Okay, so the real question is, does ovarian stimulation affect oocyte quality? Okay, I'm sure that would be a divided debate, but I would say there are 3 schools of thought, and I'm happy to tell you which one I am. But on the left, there is a school of thought, and each one of these has some supporting evidence. So there's some school of thought that say it's totally random. This is just biological variability. It doesn't really matter what we do. Each cycle, new cohort of eggs. Just keep going, and if you try enough times, eventually it will work in your way. So there's some people who say it doesn't really matter what you do in terms of stimulation. There are some who say, well, there's not that much you can change. There is biological variability, but maybe you can screw it up. So you really got to pay attention. So if you give too high doses of gonadotropin, if your stimulation protocol is really short or really long, or the timing of the trigger to PU, if you do these in extreme cases, you could have had good eggs, but because of your clinical decisions, you didn't do a great job. And of course, there's a school of thought that says everything matters. Which type of FSH? Should you add a LAGE? When do you trigger? What co-treatment sort of? Okay. But I think most of us, in the very least, would say at least some parts matter in the stimulation. So let me show you 3 abstracts based on 3 different clinic networks we've worked with that shows how magenta, an egg scoring system, can tell us a little bit about the stimulation and how that impacts the protocol. So this is a study from 2023. It was the first one we did on this topic. And it was we used about 1,667 ICSI cycles. And we looked at patients who took the GnRH antagonist and GnRH agonist. And we compared the magenta scores of all those eggs and, of course, also those outcomes. And you can see that the average magenta score in patients who had the antagonist was statistically higher than the average magenta score who used the agonist. So 5.1 versus 4.8. And this was more pronounced in the younger groups under 35, where we see it is 5.2 versus 4.7. This also correlated with the blastocysts. So overall, the blastocyst rate was 15% higher in that antagonist group. It was 37% versus 32%. Now, of course, it's retrospective. Of course, there's confounders. For example, maybe antagonists is our go-to standard of care, and maybe our agonists are people who have failed or have canceled cycles, who are older, and so forth. So, but it is one of the first studies that we've been able to show that the type of protocol, you can see it at the egg level, which also correlates on the blastocyst level. So this is just one example, and it really piqued our interest. And in ESHRE this year, we presented another topic, and this is again retrospective. This was an independent study, so it came from another clinic, and they looked at 2,603 cycles, and they looked at patients who used FSH alone or FSH and LH. In terms of number of eggs, those 2,603 cycles represented 12,564 eggs, and about 9,800 were the FSH only, and about 2,700 were FSH and LH. What I want to highlight here is that the magenta score in the younger patients was a little bit higher, statistically higher in the FSH and LH group. You can see 6.4 versus 5.9, and slightly higher in the older group, 5.8, 5.7. And again, this correlates also with lab outcomes of blastocysts. So the blastocyst outcomes were 56% overall versus 52%. And again, here is another example of how having an oocyte KPI can tell us a little bit about that stimulation, showing that FSH plus LH in the younger patient gave you a higher score, and it also correlated with more blastocysts. And here's a third article I want to show you. Again, this is very recent. This was just presented in ESHRE 2025, retrospective, independent. And the reason I love it is because sometimes, my background is statistics, and sometimes you always feel like if you split two groups, you're always going to see some difference, tall, short, skinny, heavy. And so here is actually quite the opposite example. So these are actually donor eggs. These are donor eggs that were vitrified and later on thawed to make embryos. And they were looking at using GnRH antagonists to prevent the LH surge or progesterone priming. I mean, I live in Canada. I have to tell you, North America is very behind in adopting PPOS, although I know Asia and Europe uses it quite often. So this was actually a really nice study to show my North American colleagues. But what we saw here, if you look at the egg donors using progesterone versus antagonists, the magenta score was essentially the same. They didn't see any difference on the egg quality side. And again, that also reflected in not seeing any difference in the blastocyst clinical implantation or clinical pregnancy side. So this is kind of a reassuring study to tell clinicians, look, you want to use progesterone, which is a cheaper oral alternative. It won't impact your outcomes, specifically your egg quality. Okay, so again, what I'm really trying to do is I'm trying to inspire you guys with a new way of thinking and present a new lab outcome KPI for oocyte quality that we couldn't do before. Before, we had a stimulation and we had downstream effects like blastocysts and euploid rates and outcomes. And if things didn't go well, we always wondered if it was the stimulation, was it the patient, the egg, or was it the lab? But using Magenta and AI tool, we finally have an oocyte KPI that we can add into the equation, and that can give us ways to decipher if this is egg related, and if it is egg related, is that stimulation related? So here I just put that in, suggesting that maybe we can add this into our protocols. And how can it help? Well, I can tell you, I'm one of the physicians who goes to conferences and I get very excited. And sometimes I come back and I say, guys, we need to really try to change the way we do triggers. And I think I should follow the data. I mean, if we quickly switch something in our lab and say we're going to do dual trigger instead of single trigger, for example, I would like to see the downstream effect for the next treatment. How did that impact not just my traditional KPIs, but now I have another KPI. How did it affect the egg scoring? Certainly, the pharmaceutical companies are very excited to check if certain FSH types or gonadotropins in general have an impact specifically on the egg quality, which should reflect lab outcomes as well. So the take-home message, I'll follow on that there is no egg scoring system out there. If there was, every egg in the world would be evaluated. After many years and lots of data and lots of collaboration, we now have ample evidence to show that AI is able to objectively and standardize the egg assessment. We define egg quality as the reproductive potential of the egg, and now we can put this into the lab as an oocyte KPI to add on to the other KPIs. And it's sort of the missing link between the stimulation protocol and the outcomes. It's the in-between. And the three examples I just showed you, there are some practical giveaways. Of course, they have their limitations in terms of study design and implications, but here you can make an argument that GnRH agonists should be considered maybe our first line of IVF treatment if we're focusing on egg quality. You can make an argument that LH co-treatment in the younger patients may improve egg quality and lab outcomes. And you can reassure us North American clinicians and embryologists that progesterone priming won't impact your outcomes, specifically your egg quality. So, even just considering in your egg donor group, you would have our full support. Thank you so much. The best part of these i3 webinars is always the questions, the ideas, the collaboration. So if anybody would like to reach out with a thought, with an opportunity, with a new research idea, I'm really keen to hear. Obviously, I couldn't go over all our research, but here's a QR scan code if you wanted to scan that in and read through it. I'm really looking forward to hearing from you and our third speaker as well.
Thank you for the very, very good talk for the night. So I would like to ask Dan one question from the audience. It is from Ying Lee from California. So is the patient age the only factor used to differentiate the magenta scoring? Do you also consider diagnostic factors like PCOS?
Yeah, it's an amazing question. So the question is like, where did we get the score from? So it is a visual assessment of the egg, denuded, mature egg. So obviously it takes the cytoplasmic, extracytoplasmic factors into it, but it does use two clinical variables. Age, because we know that's so correlated and it's available, and number of mature eggs in the cohort, because we've seen, for example, when we work with Japan and North America, different ways of stimulating, for example. We did not add extra clinical variables like PCOS, smoking status, mostly because this is very difficult to have with very clean data, right? If someone says, I'm smoking, how much are you smoking? When did you stop? And stuff like that. So our magenta was trying to do it as workflow efficient as possible. So it's visual plus two clinical factors.
Thank you, Dan. So thank you for the speaking. So we would like to continue with our final speaker today, Dr. Daniela Braga. So she's a reproductive scientist and veterinarian with over 150 publications in peer-reviewed journals. So she earned her PhD in medical sciences from Federal University of Sao Paulo, and is a postdoctoral researcher in animal reproduction at the University of Sao Paulo. As scientific director at the Institute Stefan Spante, she leads courses in reproductive biotechnology and scientific literature. She also co-founded Science for Every Mind and Eugen in Vitro. Her research connects human and animal reproduction, focusing on oocyte quality, embryo development, and artificial intelligence in reproductive medicine. So, Dr. Daniela, the floor is yours.
Thank you very much. Thank you very much again. Thank you for the invitation. Thank you, Dr. Gilles Palmer. Thank you, Future Fertility. It's a real pleasure for me to be here today. And today I'll talk a little bit about the artificial intelligence for the evaluation of the oocyte quality in cases of severe male factor of infertility. So those are my disclosures. I don't have anything to disclosure. Well, as we all know, according to the World Health Organization, 1 in 6 couples experience infertility at some degree during their infertility life, reproductive life. And the male factor infertility accounts for close to 20 to 30% of all infertility cases, while the male contribution, either isolated or combined with female factors, is observed in about 40 to 50% of infertility couples. And this is even more concerning when we consider the sharp drop in sperm count in the past decades all over the world. And now male factor has been considered a real public health issue. We know that sperm quality is one of the main factors that affects fertilization and blastocyst formation. And because ICSI bypasses the natural sperm selection, there is this increasing concern about the male inherent pattern in assisted reproduction. We also know that only a few sperm, less than 10, are selected from a high heterogeneous population of more than 100 million, making selection even more challenging. And so therefore, one key limitation in assisted reproduction is the lack of an effective method to isolate the most competent sperm to be used in the treatment. Well, the sperm selection methods try to mimic what happens naturally in the female genital tract. We have the classic and the advanced sperm selection methods. For the classic, they try to remove dead cells and debris, like in the density gradient centrifugation, or to select high motile sperm, like in the swim up, and sometimes both approaches are combined. As for the advanced sperm selection methods, we have many like IMICI, PICS, MAX, microfluidics, zero potential, birefringence, laser beam, and others. However, no matter which method is used to select the sperm, the embryologist will still have to choose one sperm over million, which can be time-consuming, subjective, and even cause damage to the sperm. As for the oocyte, we also know that the oocyte has a complex machinery that influences the embryo development from the very first beginning, including meiotic resumption and conclusion, cleavage after fertilization, blastocyst formation, and pregnancy. Usually the methods used to assess the oocyte quality is still the morphological analysis by conventional microscopy. However, it's highly subjective. There is no consensus in literature, and it's very difficult to do. So in this scenario, the artificial intelligence emerges to reduce the workload for both embryologists and physicians, to assist in the decision making and to increase safety, and to provide valuable information to support patients' counseling. And no matter if it is for decision making or patient counseling, the earlier the information is available, the better. And the gametes are a very good start point. So recent advances in artificial intelligence have revolutionized our field by enabling objective, reproducible, and outcome-based analysis of oocyte images. And a series of studies conducted between 2024 and 2025, notably mostly by Future Fertility, have demonstrated how deep learning-based systems, particularly the Magenta platform, can predict the embryo competence. So in this collab by Future Fertility and Ferti Group, the correlation of Magenta score with the oocyte development has been proposed. Here, we evaluated images from fresh oocytes by using the Magenta platform, which detects features that are not seen by the human eye. And as Dr. Dan just explained in the previous presentation, the Magenta gives us a score from 0 to 10, which in this study was correlated with the oocyte development. In this previous study, we evaluated 14,605 oocyte images, and we observed a positive correlation of Magenta score with fertilization, with blastulation and blastocyst quality, and even we found a positive correlation of magenta score with the euploidy of embryos. We also found negative correlations with morphokinetic parameters. And as Dr. Dan just showed, we also found different magenta score in different controlled ovarian stimulation protocols. But an interesting thing here in all these analyses that we perform is that all these analyses were conducted in a real-world population without excluding cases of severe male factor infertility. However, we know that magenta model is grounded in machine learning techniques that use a huge amount of data to predict outcomes. And despite all this, the magenta tools was initially developed without considering the male factor infertility. And we know that male factor infertility can influence the reproductive outcomes, such as fertilization, blastocyst formation, aneuploidy, and the pregnancy implantation, and so forth. So this gap in its applicability for couples facing male infertility challenges, particularly in severe cases of male factor infertility, is very important. So considering all this, our group have just published this article that had the goal to investigate how well the magenta tool performs in predicting blastocyst development in couples with severe male factor infertility. So this was a retrospective cohort study in which 14,602 oocytes images from 2,156 ICSI cycles were evaluated. The images were split into groups dependent on the presence of severe male factor infertility. So in the control group with no male factor, there were 13,124 embryos from 1,956 cycles. And in the severe male factor infertility group, there were 1,478 embryos from 200 cycles. Here we considered severe male factor infertility when less than 5 million of sperm were present in the ejaculated. So these groups, the severe male factor and non-severe male factor groups, were compared for fertilization, blastulation, blastocyst quality, and magenta score. So as for the severe male infertility group, included 109 cycles with ejaculated from couples with ejaculated sperm, accounting for 59.5% of the cases, 55 cycles from couples with obstructed azoospermia, and here the sperm were retrieved from epididymis using percutaneous sperm aspiration, accounting for 27.5% of the cycles, and 26 cycles from couples with non-obstructive azoospermia, in which sperm were retrieved from the testic by testicular aspiration. These were 17 cases, and by microsurgical testicular sperm extraction for 9 cases, together contributing for 13% of the cases. As for the demographic data, we didn't find any significant difference for the demographic data, except for the paternal age, which was increased in the severe male factor infertility. We also didn't find any significant difference in any results from the control ovarian stimulation protocol. So what we found, as expected, a significant difference in fertilization, blastocyst formation, and top quality blastocysts, where the severe male factor infertility presented lower rates for all fertilization, blastocyst formation, and the top quality blastocysts. However, as expected, we didn't find any significant difference in the magenta score when comparing the severe male factor infertility group with the non-severe male factor infertility group. As for the cumulative pregnancy, we also found an increased rate. We also found an increased rate in the control group when compared with the severe male factor infertility group. So these results show once again the importance of the sperm in assisted reproduction cycles, even when using ICSI. But an interesting thing an interesting here in our study is that when we look at the results only in the severe male factor group, what we found a difference in the magenta score. So we evaluated the magenta scores from fertilized and non-fertilized, from embryos that achieved the blastocyst stage and those that did not achieve, the high quality and low quality blastocysts only in severe male factor group. So what found here? An increased magenta score among successful fertilized oocytes, an increased magenta score among the embryos that reached the blastocyst stage, and an increased magenta score among the blastocysts that were top quality when compared to the low quality blastocysts. So this shows that the same results we found the same results that we found before, but here only in the severe male factor group. So the central question in this study was whether the magenta algorithm, which was developed without accounting for female factor infertility, would be effective when applied to the population with severe male infertility, and the answer is yes. The AI model that focuses only on oocyte quality can still provide viable predictions in such cases. So in conclusion, this study showed that AI-driven oocyte evaluation using magenta may support the assessment of fertilization and blastocyst formation in couples with severe male factor infertility. Well, I think that I still have some time, so I'll show to you some data that was just presented in the Brazilian Congress of Assisted Reproduction last month, still in the same line of research and evaluating the correlation between AI-based oocyte assessment and male factor infertility. So going back to the demographic data, as I said before, we know that 1 in 6 couples worldwide experiences some degree of infertility. And a major concern today is that the progressive delay in family planning, which has been observed in both male and female. And the impact of maternal age on fertility is well documented and studied, but it's also important to understand the effects of paternal age. What we know is that paternal age has a detrimental effect on the health of the offspring, on the sperm quality, on reproductive outcomes, and we see an increase in sperm DNA fragmentation with the increase in age of the man. We know that the oocyte has an intrinsic mechanism that is able to repair paternal DNA damage, especially when we have sperm DNA fragmentation. However, we also know that this efficiency is variable, and this variable efficiency can impair the embryo development. What we know from previous studies is that high-quality oocytes, especially from younger women, provide a better repair capacity. So in this study, we hypothesized that AI-based oocyte quality assessment could identify conditions under which oocyte repair mechanisms would either compensate for or fail to correct errors introduced by sperm from older men. So in this study, this was a retrospective cohort study in which 13,612 images from 3,696 cycles were evaluated. Here, we split the groups according to the paternal age, so over 40 years old and lower than 39 years old. And we also, in these groups of paternal age, we also split the images according to the magenta score. Here we use this 6.4 that split the population in 50% lower than 6.4 and above 6.4. So we split the groups in low magenta score and high magenta score, and then we compare these 4 groups according to the fertilization, blastulation, blastocyst quality, and the chromosomal status. We also evaluated the clinical outcomes, but here obviously we evaluated only 1 magenta score, a variable per cycle. So we calculated the average magenta score for all simply embryos of that patients, and then we compared it with pregnancy, implantation, and miscarriage. And we also performed the logistic regression models. An interesting here is that we performed interaction models to evaluate if there was an effect, if the effect of paternal age on outcomes would be modulated by magenta score or by maternal age. So what we found here was we didn't find any significant difference when we compared the paternal age independently, but we found a significant influence of the magenta score on the blastulation. And here, when we see the low magenta score with high paternal age and the high magenta score with high paternal age, we see the significant difference, showing that the magenta score attenuates the detrimental effect of the paternal age on blastulation. As for the euploidy, we didn't see the same, but here we see the advanced paternal age has a magenta score independent effect on euploidy, since we didn't see any difference when low magenta score and high magenta score was compared. And when we look at the multivariable models, we saw a significant decreased chance of fertilization when the paternal age was increased. As for the magenta score, we see important influence of the magenta score on the odds of fertilization, magenta score as well. As for the blastocyst formation, we also see an influence of the magenta score in the blastocyst formation. We saw that the oocytes in the high magenta score group had more than twice times chance of achieve the blastocyst stage. But an interesting thing here is this interaction that we found here. So we found the significant interaction between paternal age and magenta score and paternal age and maternal age, which shows that lower maternal age and higher magenta score may attenuate the negative effect of advanced paternal age on blastulation. As for blastocyst quality, we still see an important influence of the magenta score, also maternal age. And for the euploidy chance, we saw obviously an important influence of the maternal age, but here again, we see an important interaction between paternal age and magenta score. So for each additional standard deviation in maternal age, that here was from 3 to 5 years, the negative effect of paternal age on euploidy increased by 6%. As for the clinical outcomes, we also here see the significant influence of the magenta score. We see higher magenta score is associated with better clinical outcomes, especially in younger fathers. And as for the multivariable models, we saw again an influence of magenta score for cumulative pregnancy of the maternal age. We again see the interaction between paternal age and magenta score, showing that the detrimental effect of advanced paternal age on pregnancy outcomes may be attenuated by a high magenta score. So on conclusion, this data show that oocyte quality is the most decisive factor for embryo development and pregnancy. Magenta score consistently predicted better laboratory performance and clinical outcomes. The effects of paternal age are context dependent. The adverse influence of advanced paternal age are attenuated when the oocyte quality is high. The maternal age is still a critical factor, obviously. Increasing maternal age negatively affects both labs and clinical outcomes and amplifies the effect of paternal age on euploidy. And combining AI-based oocyte quality assessment with paternal age provide a more accurate framework for prognosis and counseling that considering each factor in isolation. So thank you very much. If anybody has any doubts that want to talk to me after, this is by my mail and my Instagram and all my contacts. Please feel free to contact me. Thank you very much.
Thank you so much, Dr. Braga, for this very nice and comprehensive presentation. There's some questions in the audience in regards to the workflow and implementation of these AI algorithms in the clinical setting. And my question comes into that direction. How, in your clinical setting, how do you treat, in the end, an oocyte? The magenta score is you showed us it's really validated in an oversimplification. An oocyte that has a higher magenta score is more likely to fertilize, to generate a blastocyst, even to be an euploid blastocyst. But how do you cope with the difference in the magenta scores towards other algorithms, embryological in the development of embryos, such as IDA score, or what the whatever fertility, fair fertility, whatever, and also the morphological assessments of the embryology is what we actually like to do.
In the infant group, what we have the embryoscope. So we have all the morphokinetic parameters and also the IDA score, the KID score, and obviously the magenta. So what we do, and obviously the embryologist opinion. So what I saw here is that I didn't have time to show is that we did saw a correlation of a magenta score and morphokinetic parameters. So when I see that there was a negative interaction, a negative influence, is that as the magenta score increases, the time for the embryo to achieve some morphokinetic factors such as pronucleus appearance and failure, time to reach 2, 3, whatever. So the time to reach these milestones are decreased as the magenta score is increased. The same for the IDA score. So the IDA score is positively correlated with the magenta score. So most of the times, the magenta score talk the same language than the morphokinetic parameters and the IDA score and the embryologist opinion. But if we have anything different, obviously we have to look at one case by time, one case independently of the other. There is not a rule. Have to look at the case and see what the embryologist think, see what the IDA score says, what the morphokinetic says, and what the euploid evaluation, the PGTA sometimes says, and then we decide which you want to transfer.
Yeah, not easy. Thank you so much. I think it's now time to move to the Q&A section, in which we are going to treat the rest of the questions that have been written by the audience. Julian, do you want to start?
Sure. Maybe one quick question for Daniela while we have her still focused is there's a question from the audience. How does AI fit into your workflow? So maybe within the labs or with the clinicians, how easily is this implemented in your clinics? Oops, sorry, Daniela, you're on mute, I think. Oop, did we lose Daniela?
I think she froze.
Yeah, I'm sorry. I have
maybe Dan can jump.
Sure, Dan, do you want to comment on integrating AI such as our oocyte assessments into your clinic and workflows?
Sure. So, I mean, when we developed specifically the magenta, we tried to do it to not impact the workflow. That was the first thing we learned, that it doesn't matter what the technology is. If it impacts the effort, no one's going to use it. And so the magenta, again, is a camera on your microscope, and it's after denuding. So you can either take a picture before you freeze it, take a picture before you do an ICSI. So we use it at one of our clinics at all the egg freezing cycles. We didn't talk about that, but that's a product called Violet, where you take pictures of the eggs and you try to personalize a prediction of the quality of the eggs. Otherwise, you just have age and number of mature eggs to go by. But in Magenta, I personally use it as a clinician in my low prognosis patients. We all have patients to, have a 5%, 10% chance. They're older, they failed multiple cycles. I anticipate that I'm probably going to be sitting with them having a difficult conversation. It's still difficult for them, even if they know they are low prognosis. And it's been very helpful to show them that the egg scores are quite low, and this is, not a reflection of our lab. And in fact, maybe moving on to egg donation makes a lot of sense. So for me, it helps very much in a counseling tool for the low prognosis patients. I was just stalling for time till you're back, Daniela.
Daniela, did you want to add any additional
Thank you.
comments with respect to that?
Yeah, sorry, I just came back in. I don't know. I just felt. Can you repeat the question?
The question was just, what does the integration of AI into your workflow in the clinics look like, or how is it adopted?
Yeah, we already had other AI technologies.
Is it implemented?
We already had other AI technologies in our lab, so it wasn't really new for us to use the magenta and the violet as a tool to evaluate the embryo and the oocyte and the embryo, and to help to decide which embryo to transfer, and even to decide which embryo to go to PGTA and all this stuff. So it, of course, in the beginning, as all technologies, it's a little bit more difficult to put in the routine, because in the routine in the lab is crazy, but it wasn't difficult at all, and it helps a lot.
Amazing, thank you.
I would like to ask a question to Dan. It is from Dan Nayot. Nice talk, Dan. Watching here in Sydney at 7 a.m. So average differences look great for the developmental potential. And have you assessed sensitivity or specificity and AUC for the magenta?
Sorry, I didn't think I heard the whole thing, but I think the question is about like accuracy, sensitivity, AUC of
Yeah.
magenta. Yeah.
Yeah.
So, I mean, I didn't go into that. Those were the 65 abstracts that we sort of have done over the years with internal and external data. I would say that the accuracy continues to improve. How do we do that? Is we keep getting more data sets. The AI, algorithms keep improving, and we keep tweaking it. In terms of area under curve, it really depends what we're measuring. Egg to fertilization, so this is very short. Egg to blast, egg to high quality blast, egg to euploid. But Julian, maybe you're better to answer this than me. But I mean, at the moment, our AUC, area under the curve, from egg to blastocyst, I think is about 0.71 or 0.72. Is that correct, Julian?
For our euploidy predictions, yes, but for
So that's from egg to
blast
euploid. Yeah.
is about 0.69, 0.7.
So, but what I want to highlight, I think is important, is the comparison. An embryologist, so it doesn't matter how much experience or how bright you are, because of their eyes and their inability to remember their 75th eggs ago, the ability to go from egg to predict to blastocyst, we've done this study many times, is about 0.52, just above random. And the confidence doesn't impact, even the ones you think you're sure about, that doesn't impact your accuracy. So the delta between the human and the machine is what's exciting for us, because this is one of the few AI applications where it's not just faster, cheaper, but it's actually doing something a human cannot do with their eyes. And that's like, what I'm saying is valid, because if there would be an egg scoring system, right? If there was a correlation with what we can see in outcomes consistently, there'd be some egg scoring system.
Thank you.
All right, I think I can jump in. Bronte Stone from the USA asked whether there is an outstanding element of morphological abnormality which characterizes oocytes from older oocyte providers, like such as aneuploidies. Maybe Dr. Franco can give us some insights here.
Yes, several recurrent morphological abnormalities are significantly more common in oocytes, specifically from older patients, and they are going to be correlated with the increase in aneuploid risks. And then when you have to check the oocyte, no single feature is perfectly predictive, but when it's increasing the age, is a correlation and it's more prevalent, this kind of abnormality in the oocyte and are related with the aneuploid.
Thank you very much.
You are welcome.
I think it's my turn maybe for a question. I'm trying to find one that would be good to answer. I don't know if anyone else has anything they want to jump into.
I can, if you like, and until you find your question.
Okay, thank you.
So I'm going to be a conflict of interest. So my lab director is asking from Cyprus for Daniela. So according to our data, with around 3,000 oocytes, we observed higher degeneration rate and also higher 1PN rate with low magenta score oocytes. So do you have similar early findings in your cases?
So what is that? What did you find?
So we observed higher degeneration rate.
Okay.
Degeneration rate and also higher 1PNs rate with low magenta scores.
Okay.
So
Yeah.
do you have similar early findings in your cases also?
Yeah, generation rates, yes, we found very low magenta scores. And with 1PN, we didn't evaluate that. I'm not quite sure if the magenta score is low, but it's a good question and a good idea. Maybe we could perform a study looking at that. But no, I don't think as for the abnormal fertilization, we didn't find any difference. We find between fertilized and non-fertilized, but not for abnormal fertilization, no.
Thank you.
There's a question for Yosu. Do you report the oocyte morphological assessments to the patients, whether that's from the embryologist or from any sort of AI report, and what do you share with them?
Always after the retrieval and before the patient they are leaving, when we have to get out the granular cells from the oocyte, we take the picture and the photo and we report how is the quality of the oocyte, because it's important from the beginning. The patients, they have to have this kind of information and can help us in case the cycle is you are not going to have any blastocyst or the quality of the blastocyst is bad. When you have before this kind of pictures and you can relate it how is going to be the prognosis for the cycle, the patients, they are going to release and also they are going to figure out or understand much better what is going to happen.
Wonderful, I agree. I think all information is helpful information.
Yeah, always. Yeah.
Thank you. Does Nacho or Munevver have another question for our speakers?
Yes, maybe to make it clear here, Alessandra Videcche from New York asked whether the magenta rely more on oocyte kinetic properties or morphological features.
Maybe a question for Dan.
Sorry, you're gonna have to repeat that. I apologize.
Does the magenta rely more on oocyte kinetic properties or morphological features? So is it a static image or is it?
It's a great question because again, I like the question because it actually sparks the ideas. But it was designed on static 2D images of mature oocytes. But over the years, we keep thinking like, wouldn't it be amazing to do a 30-second video? Wouldn't it be amazing to watch embryologists always have some sense when they're doing their ICSI techniques. We don't have that. We are working on that, but it's designed on a static image, so just morphological, not kinetic.
Would definitely be very cool.
It would be cool. Yeah.
Great. Here's a question that maybe can be answered maybe from Dan and Daniela. Parizia comments that usually LH is recommended in patients over 35 years old, but in the research from Daniela and that Dan also shared, according to Magenta, perhaps the results are indicating the opposite, and that we saw the biggest effect on oocyte quality in the younger patients. Any comments, thoughts there?
Yes. Well, in this study, the study that we sent to sorry, Dan, can I answer that?
Oh, please, you know it better than me.
Okay. In this study that we sent to ASHRI, it was the previous study that we did together with fertility. We really, when we look at the whole population, we didn't find any significant difference in the Magenta score when comparing the use of FSH exclusively and FSH plus LH. But then when we split into different populations, we found a slight difference for the young patients. But what we did after, we increased the number of patients in this study because we found this was a little bit weird. And then we did a propensity matching score with the number of retrieved oocytes and the age. And then we did we analyzed the whole group again. So what we found for the whole group, we still didn't find any significant difference in the Magenta score when LH was compared with LH plus LH. But when we split in different populations, here we found the opposite of what we found before. So here we found an increased Magenta score among oocytes from cycles stimulated with LH plus FSH when compared to the only FSH group. So here we see the importance of treat the group, the study group well. So we did a simple difference, and of course we increased the number of patients included in the study. We increased the number of oocyte images, but only doing the propensity score matching, we could see a different result, which makes much more sense for us. Sorry, Dan, that you have to present this before, but hopefully in the next year it will be presented in ASHRI, I hope, in ASHRI.
Thank you, guys. So I think our time is up and we would like to go for the closing. So we would like to thank all those who joined today's session. My sincere thanks to my co-host, Dr. Nacho Landaburu Marie, and our dearest friend, Julian, and also our speakers today for Dr. Yosu Franco and Dan Nayot and Daniela Braga. I would like to special thank to Future Fertility for supporting this event. So, Nacho?
Yes, thank you so much, Munevver. It was really, really interesting. I would also like to point out and to recognize the I3 organizing committee. Thank you, everyone. Thank you, Jax Cohen, Peter Nark, Marianne Sevaites, Thomas Elliott, Fran Farley, Violetta Soda, and Gilles Palmer. Thank you, everyone.
Likewise, thanks to our co-hosts and everyone on I3. Thank you for allowing us to have this discussion today. I think it was wonderful. And please join us again to talk about hot topics and the latest publications of our BMO focusing on cryopreservation on December 9th for the next I3. Thank you, everyone.
Thank you.